Welcome back to the deep dive. Today we're digging into something genuinely transformative, I think, in the world of health. We're looking at a really fundamental shift in how cardiologists are starting to understand and, well, fight heart disease.
Yeah.
Yeah, our main source here is a fascinating article by Dr. Edward Litham. It's called Cardiologists and a New Enemy, Evolving Tools of the Trade. And our mission really is to unpack this huge reorientation in heart care, what it means for stopping serious illness, and maybe look at some of the exciting new tools coming online. It feels like more than just an update.
Oh, absolutely. What's really striking in Dr. Latham's piece is he calls it a renaissance, basically, in medicine. He argues it's changing not just treatment, but how we even define the enemy when we talk about cardiovascular health. And interestingly, that enemy isn't quite what many people might traditionally think it is.
That's a great way to frame it. So let's just rewind a little. The old way, the old paradigm in cardiology.
Yeah.
What was the main thing we were looking for? When you first trained, what was the enemy?
Well, back then, it was almost laser focused on flow-limiting narrowing, blockages in the coronary arteries.
Right.
We were really zeroed in on those main pipes feeding the heart muscle.
Right.
And the gold standard, invasive angiography. Basically sticking a catheter in, injecting dye, and getting an X-ray map.
Right. You could see the blockage.
Exactly. If you saw a significant narrowing, that was the danger zone.
So the key things were like how many arteries were blocked, how tight the narrowing was, plus blood pressure, cholesterol, maybe the heart's pumping strength, the ejection fraction, and diabetes. It was a risk factor, obviously, but kind of managed on the side, right?
Yeah.
By endocrinologists or GPs mainly.
Precisely. It was acknowledged, but often treated as a separate issue. The main cardiac focus was on the plumbing, the physical blockages. A narrowing equaled risk. An occlusion needed fixing, usually with a stent or bypass.
Okay, but Dr. Latham says this whole foundation has shifted. What's the big change? What's driving this renaissance?
Right, this is the core of it. The really profound insight, especially over the last decade or so, is that future risk, things like coronary thrombosis, it's driven less by how narrow the artery looks on that angiogram.
Yeah.
And far more by the degree of inflammation that's actually simmering within the plaque itself.
Inflammation, okay.
Yeah. Outside of an acute heart attack scenario where you absolutely need to open that artery immediately, it's that underlying, often invisible inflammation that's predicting future trouble. That's the real game changer.
And does this tie into diabetes differently now, too?
It absolutely does. We used to think of diabetes almost like an on-off switch. You either had it or you didn't. But now we see cardiovascular prognosis, your outlook, is linked much more to a whole continuum of glucose dysregulation. It spans the entire HbA1c spectrum.
So even if you're not officially diabetic?
Exactly. Even if your HbA1c is in the normal or pre-diabetic range, where it falls on that spectrum matters. Put simply, the lower your HbA1c generally is, the better your cardiovascular outlook tends to be. It really puts metabolic health, how your body handles energy and sugar, right at the center. That's the new battlefield for preventing heart disease.
Wow, okay. That completely reframes things. It's not just about unblocking pipes. It's about cooling down inflammation and sorting out our metabolism. So if that's the new enemy, the sort of metabolic dysfunction, what's in the new arsenal? Are we talking completely new drugs or using old ones differently?
It's a bit of both, actually, and some of it is quite surprising. Some of the biggest breakthroughs involve drugs originally designed for diabetes having these incredible heart benefits.
Right. I think that catches a lot of people off guard. Can you give some examples?
Sure. Take the SGLT2 inhibitors. These were diabetes drugs, first and foremost. But huge trials show they give just unequivocal, really significant improvement for patients with heart failure. And here's the kicker. Regardless of whether those patients actually have diabetes or not.
Regardless of diabetic status. Wow.
Yeah, a drug for blood sugar, revolutionizing heart failure treatment for everyone. It's massive. Then you have the GLP-1 receptor agonists. Remember the big semaglutide trial last year? It showed really striking survival benefits, even for patients who didn't have diabetes but did have existing coronary heart disease.
So the takeaway isn't just managed diabetes. It's more like the real danger is this broader thing, metabolic dysfunction, like obesity, that fat around the organs, insulin resistance, even subtle glucose issues.
That's exactly it. It's a much wider target.
Okay, so how do we actually find this hidden enemy earlier? What are the new diagnostic tools?
Well, that's where things get really interesting, too. Our diagnostic toolkit has expanded significantly. For instance, we can now use AI, artificial intelligence, to analyze standard cardiac CT scans in a new way. It looks for coronary inflammation by measuring something called the Fat Attenuation Index, or FAI.
FAI, what is that exactly?
Think of it like this. It measures the inflammation in the fat surrounding the coronary arteries. More inflammation there is a strong sign of risk within the artery itself. It's something we couldn't easily quantify before.
Okay, so like seeing the heat around the artery.
Kind of, yeah. And then there's continuous glucose monitoring CGM.
Ah, those little sensors people wear.
Exactly. You wear a small sensor, often on your arm, and it gives you a constant stream of data about your blood sugar levels,
Yeah.
24/7. It shows you exactly how your body responds to different foods, stress, exercise, in real time. It can pick up alarming glucose spikes after certain meals, well before your HbA1c might even creep into the pre-diabetic range.
That sounds incredibly powerful, getting that immediate feedback. What else?
We're also using low-dose CT scans, sometimes the same scan used for the heart, to measure visceral adipose tissue, or VAT.
That's the internal fat, right? The dangerous stuff.
That's the one, the fat deep inside, around your organs. High levels of VAT are a major driver of insulin resistance and poor metabolic health. And here's the thing. You can have high VAT even if your body mass index, your BMI, is perfectly normal.
So someone could look lean, but still have this hidden risk factor.
Precisely. Dr. Leatham mentions an example image, a patient with a VAT score of 289 centimeters stavs. The healthy threshold is generally under 100 centimeters stavs. That visual really hits home, regardless of weight.
Okay, so we identify these issues, the inflammation, the glucose spikes, the VAT, beyond the new meds. What about lifestyle? How do these tools help with non-drug approaches?
This is where it gets really empowering for the patient. Those CGMs, for example, they're not just diagnostic, they're educational tools. Seeing right there on your phone how that bowl of pasta sent your glucose soaring, that immediate feedback helps you tailor your food choices way more effectively than just getting general dietary advice.
It makes it personal.
Exactly. We can combine that with food analysis apps to help people understand macronutrients better, maybe even DNA testing to spot specific vulnerabilities or how you might process certain foods. And then tracking progress is key. Simple things like measuring your waist circumference, using home body composition scales, maybe periodic DIXA scans or follow-up low-dose CT to see if that VAT level is coming down. It makes the interventions tangible.
This really feels like it's redrawing the map of prevention. We
Yeah.
used to talk about primary prevention, healthy people, GPs, lifestyle advice, maybe statins, blood pressure control, and then secondary prevention. That was the cardiologist's job after a heart attack or a stent or bypass surgery, keeping things from happening again.
Right, those were the two distinct camps.
But based on what you're saying, those lines seem blurry now, or maybe just gone.
I think Dr. Leeson's point is they've essentially collapsed. That binary just doesn't fit the reality anymore. Think about it. You have a patient, no symptoms at all, but a CT scan shows extensive plaque in their coronary arteries. Maybe their FAI score is high, indicating inflammation, or their CGM reveals significant glucose dysregulation. Is that person low risk? No. They might be at just as high a risk of a major event as someone who's already had a heart attack.
So starting them on, say, a GLP-1 drug or really intensive lifestyle changes isn't primary prevention in the old sense?
Not really. It's aggressive intervention based on their actual measured risk, which is high, even without symptoms yet. It's a spectrum of risk, not just two boxes.
That must be a very different conversation to have with someone, showing them that kind of concrete evidence of risk.
Oh, it's incredibly powerful. Dr. Leatham describes it well, sitting with a patient, showing them a scan with a vividly inflamed plaque, maybe in a really critical artery like the LAD, the widowmaker, and then showing them a risk score, like from the Kerry heart analysis, saying their 8-year mortality risk without intervention is, say, 15%.
Wow.
That completely shatters the illusion that heart disease is something abstract or only happens to other people. It makes it immediate, personal. That visual evidence is probably one of the biggest advances in actually motivating people to make changes.
And you mentioned this goes beyond just the heart. There was a connection to cancer risk, too.
Yes, and this is another fascinating expansion. Traditionally, if your family history was loaded with heart disease, we'd be very aggressive with lowering cholesterol, right?
Sure.
But if the family history was dominated by cancer, the rationale for, say, high-dose statins might have felt a bit weaker to some. But what's emerging now is that visceral adipose tissue, that VAT we can measure on CT, isn't just linked to heart disease. It's also proving to be a potent risk factor for several types of cancer.
Really? So that hidden fat is bad news on multiple fronts.
Exactly. You could have someone feeling perfectly fine, asymptomatic, but their scans show significant plaque, maybe CGM shows glucose issues, and they have a high VAT burden, over 200 centimeter box sets. That person isn't just facing elevated heart risk, their cancer risk is significantly elevated too, often for the same underlying metabolic reasons.
So interventions like diet changes, exercise, maybe those GLP-1 drugs, they could potentially lower both risks at the same time.
That's the exciting possibility. Things like serious dietary restructuring, adding resistance training, using GLP-1 mimetic therapy, these might tackle the metabolic dysfunction that fuels both cardiovascular disease and oncological processes. It means cardiologists are finding themselves moving into this broader space, maybe call it longevity medicine, addressing the root causes that impact multiple major diseases.
Incredible. So for you, the listener wanting to engage with this new paradigm, how do people typically get onto this pathway? Dr. Leatham mentions two main routes.
Right. The first is still the more common one, symptom-driven. Someone comes in with chest pain, shortness of breath, palpitations, whatever it might be. But now the investigation is often much broader. It's not just an ECG and maybe a stress test. It's increasingly likely to involve a cardiac CT, that FAI assessment for inflammation, measuring VAT, and doing detailed metabolic blood work, maybe even CGM. It's a deeper dive from the outset.
Okay, so symptoms trigger a more comprehensive workup. What's the second route?
The second route is proactive health screening, and this is definitely growing. You have health-conscious individuals just wanting to know their risk. And increasingly, you see employers offering more advanced health checks for their workforce, realizing the benefit of early detection. These packages might include cardiac CT, CGM analysis, VAT measurement, aiming to catch risk factors long before they cause problems.
Being proactive rather than reactive.
Exactly.
And from the cardiologist's perspective, especially someone who maybe spent years doing procedures in the cath lab, Dr. Leatham says this shift is, well, transformative. He even shares a line he uses with patients.
Yeah, the line, I used to stent, now I prevent.
That says a lot.
It really does. And it's not about abandoning the old skills. Stenting is still crucial in emergencies, but it's about expanding the mission. The focus used to be mainly on the visible blockages. Now, it's also about tackling that invisible enemy, the metabolic dysfunction, the inflammation, the visceral fat that fuels not just heart disease, but potentially cancer too. It's a bigger fight.
Okay, so let's try and wrap this up. We've covered a lot of ground on this new enemy, new arsenal idea. The core message seems to be the main enemy in 21st century cardiology isn't just the physical blockage, the stenosis. It's this sneaky triad of poor metabolic health, that hidden visceral fat, and chronic inflammation.
Those interconnected drivers.
Right. And the weapons have evolved way beyond just stents and basic statins. We're talking coronary CT with detailed plaque analysis and FAI for inflammation, continuous glucose monitoring for real-time metabolic insight, VAT measurement to see that hidden fat, plus these powerful newer drugs like GLP-1s and SGLT2 inhibitors, alongside really personalized diet and lifestyle plans.
A much broader toolkit.
Yeah. And prevention isn't just primary or secondary anymore. It's this whole spectrum of risk that needs earlier, more tailored, and often more aggressive action based on these new insights.
Which I think leads to a pretty important question for all of us, really. The fundamental enemy, heart disease itself, hasn't changed its impact. But our understanding of it and our ability to fight it, our arsenal, has dramatically shifted. And maybe, just maybe, in developing these new ways to combat metabolic dysfunction, cardiologists are becoming something more. Perhaps the clinicians of longevity itself.
That's a fascinating thought to end on. Really shifts the perspective, doesn't it? We hope this deep dive has given you a clearer picture of just how quickly things are changing in heart health and prevention. Perhaps something to think about for your own health journey. Thanks for joining us on The Deep Dive.